So I want to welcome everybody to today's webinar, Tackle Your Lesion Coating Troubles with Shay Lunt. And as you can see, Shay has lots of credentials. She's a CPC, CPMA, RHIA, PMP, and I've had the fortunate I've been able to work with Shay for the last couple of years, and I've really enjoyed getting to know Shay. Shay works on our professional fee side of coding. She does a lot of coding education, auditing, and compliance, serving both coders and physicians. She earned her bachelor's degree in health information management and a master's degree in health services administration from the University of Kansas. Shay is currently living in Kansas with her daughter Juniper Marie and her husband, and she is about to have her second daughter here in about, ooh, Shay, what is it, another 6 weeks, I think? Pretty close.
Yeah, we're getting down to the wire.
Wonderful. Well, Shay, at this time, welcome, and I think I will let you take it away.
Okay, sounds great, Kathy. Thank you for the welcome and welcome everybody. We are excited to have you here today. We're going to talk about lesion coding. So we will, some of these notes can be tricky as far as what information do you need to code to select the codes, and that goes for CPT and ICD-10. So we're going to look at some examples, some coding guidelines, and some codes themselves to determine what codes can be built together and what information is needed to code for these lesion removals. So it's a pretty common procedure that's done in a lot of offices. And I thought we'd start by just looking at skin anatomy. So there's 3 layers of the skin, the epidermis, dermis, and subcutaneous. And then also part of these layers are going to be some different structures. So you can see like hair follicles, sebaceous or oil glands, and sweat glands are in there as well. And then we have arteries and veins that are taking care of the blood supply to the skin. So when we look at the definition of excision and then also our repair codes, we're going to kind of reference these layers of skin. So I wanted to give you this image so we can all kind of keep it in the back of our mind as we go through here. So let's talk about what information we need to know for this CPT coding of lesion removals. These definitions here, they really go hand in hand with that information that we're going to need. So we have a lesion, and that's going to be any area of abnormal tissue change. And this can be on any organ, and here we're just talking about skin. And then we have the excision, so that's going to be a full thickness, so through the dermis, removal of a lesion, and that includes margins. And margins are important for coding when we look at the size, but what a margin is, a surgical margin, is it's defined as the edge of the tissue removed. So the term is especially important when the tissue that's being excised is suspected of being involved in some kind of malignancy. So there's some kind of neoplastic process going on. And the margin is really one of the most important predictive and prognostic factors of a malignant lesion, and that is whether the margins of that specimen are involved by the neoplastic tumor or not. So you'll hear me talk about margins a lot. And then the last one is repair. And what we mean by repair is just the closure of the defect created. So that defect is what was created when that lesion was removed. So benign or malignant, you might be thinking ICD-10 right away, but it actually comes into play in both our diagnosis and our CPT for these lesions. So there's 3 major types of skin cancers. We have basal cell carcinoma, and those are in the purple box down below. And then we have squamous cell carcinoma. So you might see BCC for basal cell carcinoma or SCC for squamous cell carcinoma, and then we have melanoma. So the basal cell and the squamous cell, they're grouped together, and they're just considered non-melanoma skin cancer. And there's a couple other types that are pretty unusual, but those include Merkel cell tumors or dermatofibrosarcoma type tumors on the skin as well. But a lesion can really be almost any abnormal change, like I said, involving any tissue or organ that's due to either disease or injury. Here we're particularly talking about skin lesion. And a benign lesion is just non-cancerous, where a malignant lesion is cancerous. So a biopsy of a skin lesion will tell the physician the difference, and that'll prove it to either be benign or malignant, or it could be a situation where it's evolving or a pre-malignant lesion as well. So like I said, we need this information for both ICD-10 and CPT coding, and the diagnosis is actually kind of the first step in determining where to go in your CPT book. So that's kind of unusual in CPT, but for these lesion excision codes, there is a difference there. So the lesion procedure itself is fairly simple. The first step is really the anesthesia. So that can be local anesthesia, it could be intravenous, it could be general. The physician who's doing the excision will determine whatever is best. If it's local, you'll see later on that's probably going to be included in our CPT code. And then after anesthesia comes the removal. So the small or contained lesion, it might be removed completely with an excision, and that's again a fairly simple surgical process. And then the last step is repair. So the removal and the repair are where we find some coding differences, and kind of depends on what exactly is done. So we'll kind of walk through that. And there's different types of removal and repair that are done depending on the size, the location, the preference of the physician, to best excise the lesion and determine what's going on. So let's start by looking at our benign lesion excision code. So this table is actually really handy. If you're looking in your CPT book, the CPT codes are a little bit hard to read just because of how the descriptions are laid out, but the codes themselves are divided by size, and the size is defined as the excised diameter, including margins. So we'll look at some examples of that, but you can see the size down the left-hand side of your screen. And then on the top, they're divided based on the location. So you'll see the different body areas that have been grouped together, and then you can kind of use your table to find the size, and the location will give you your CPT code. So this table, if you're coding a lot of these, you might want to keep it handy, just for a quick reference. Some important notes about these codes. These codes are not going to be used for a biopsy, shaving of a lesion, or destruction of either a benign, premalignant, or malignant lesion. So if it's a biopsy, a shave, or destruction, those are going to have different CPT codes. Also not used for excision of a pressure ulcer. Those wound care codes are located in a different part of CPT. And then also not used for excision of a pilonidal cyst. So those are the cysts that occur usually between the cheeks of the buttocks and at the upper end of the buttocks. So that procedure actually has its own CPT code as well. And then just a reminder, if it's unusual or complicated, you can add modifier 22. I'll talk about that more in a little bit, and then the eyelids as well. We'll talk about that today at the end. And then here's our malignant lesion. So like I said, the diagnosis is going to make a difference because we need to know benign versus malignant to choose our CPT codes. So here's our malignant ones. You can see kind of divided similarly by size, and the size is defined as the same as our benign. So excised diameter, including margins, is going to be our size. And then we have the different body areas at the top, and you can locate your CPT code there. So those are our two sets of excision codes, and I want to talk a little bit more about this excised diameter because Sometimes it's not so straightforward. So like I said, the code selection is determined by measuring the greatest clinical diameter of the lesion and then plus the margin that's required for complete excision. So it's going to be lesion diameter plus the most narrow margins that are required, and that's going to be your excised diameter. So the measurement of the lesion plus the margin is going to be made prior to the excision. And the excised diameter is going to be the same whether the surgical defect is repaired with a straight line or if it has to be reconstructed like with a skin graft. So, and this again works the same whether the lesion is benign or malignant. So in this example, the lesion is 1 centimeter and the margins were 1 centimeter. So the lesion itself is going to be the diameter. So that's one thing to keep in mind. It's not the area, it's the diameter. So 1 centimeter lesion, and then you add the margin. So here we added 2 centimeters for the margin. So we have a total of 3 centimeters. That's going to be the measurement used to pick our CPT code. And we have a couple more examples of this. The sizes in your CPT book are all in centimeters. So I know every once in a while I'll see measurements done in millimeters. So always remember to convert those over to centimeters if you're seeing that in your note. Sometimes the notes will give you measurements. So they'll say it's like in this instance a 1 by 3 centimeter lesion. So the diameter would be 3 in this case, but sometimes it's going to be sometimes they'll give you measurements such as 1 by 3, sometimes they'll just give you the diameter, sometimes the margins will be already added in for you, sometimes the margins will be listed out separate and you have to add them together. So there's not a set way that the notes must be documented. It's really up to the provider, but it is, there is some examples in your CPT book, and these examples here are good to help figure it out. So recently, we've seen some audits where there's excisions done, but there's no measurements given at all. So unfortunately, in those cases, best practice is really that you can only code the lowest code, so the lowest measurement in that code set. So that's really something to work with your providers on if you are seeing that. We do need the measurements for the correct CPT code. And then also we've gotten the question about path reports. So in a couple of those cases we've seen recently, the path report shows a pretty large lesion that was removed. The path report doesn't contain the prior to excision measurement, and that's what CPT says you have to use for your CPT code selection. So unfortunately, again, we're stuck using that lowest code in those cases. So one more example here for excised diameter, and this one is in millimeters. So this was a small lesion, but you can see 5 millimeter lesion. So 10 millimeters equals 1 centimeter. So you're just going to move the decimal over one place. So we have a 1/2 centimeter lesion, and then in this case we have 2 millimeters margins on each side. So a total of 0.4 centimeter margin. So this one's going to be an excised diameter of 0.9 centimeters. All right, this brings us to our first polling question.
Okay, let me launch the poll for everybody. I just lost my mouse. There we go. So we want to hear from you. So the question is, what is the excised diameter of a 3 centimeter by 3 centimeter lesion that was removed with a 0.5 centimeter margin? Is it 4.0 centimeters? Is it 10 centimeters? Or you're not sure? So what is the excised diameter of a 3 centimeter by 3 centimeter lesion that was removed with a 0.5 centimeter margin? Your choices are 4.0 centimeters, 10 centimeters, or you are uncertain. Okay, so we've got some of the responses have been coming in. Anybody else want to weigh in on this? Oops, boy, I already hit 100%. Perfect. Okay, I'm closing, sharing the results, and hey, this is clear cut, Shay. Everybody in our audience is saying the answer is 4.0 centimeters. Oops, Shay, are you muted, I'm wondering?
I'm muted. Sorry, I'm unmuted now. Yeah, good job, guys. So that's correct. It's 4 centimeters. Every once in a while, I will want to take the area and try to multiply the 3 by 3, and then, the answer would be 9, but that's not correct, so I'm glad nobody did that. And you guys got the 3 centimeter diameter lesion plus the 1 centimeter margin total. So 4 centimeters, great job, everybody. All right, so now we got the diameter down. Let's just talk about what's included in the excision code itself. So it does include full thickness removal of a lesion. So that's going to be through the dermis, and that includes margins. It includes local anesthesia, and it includes simple, non-layered closure when performed. So sometimes it's so small they don't even do any kind of sutures, but a lot of times you will see sutures, and a lot of times they are simple, but sometimes they're more complicated. And then if they procure a biopsy from that lesion at the same time, that's going to be included as well. So you won't code the biopsy separate if it's from the same lesion at that same encounter. Some things that are not included are going to be listed here. So repair by intermediate closure, and those codes there, so 12031 through 12057, and then we have repair by complex closure, and then or reconstructive closure. So any other type of closure besides simple is going to be separately reportable. So this is something you're going to want to look for the documentation, and we're going to take a look closer here at the coding guidelines here. So if you're familiar with the wound repair coding, you'll see the excision coding guidelines are just slightly different. So for instance, even if there are multiple lesions that are removed in the same areas that are grouped together by CPT, you would still report them separately. So like I said, if you're familiar with wound repair, you're used to kind of grouping the like repairs that are in the same body areas together. For excisions, you're going to report separately each lesion that's excised. I mentioned this earlier, but just to really emphasize, the excised diameter is going to be the same whether it's repaired linear or if it's reconstructed like with a skin graft. You can add modifier 22. This is a question that has recently came up to us in audits as well. We just want to caution again with modifier 22, you have to have documentation to support it because in order to be paid any extra, the payer is going to want the op report. So it's going to need to support things like increased intensity time, technical difficulty, severity of the patient's condition, physical and mental effort required. So again, that's just something we've been seeing lately. So if you want to submit with modifier 22 for increased procedural services, definitely make sure your documentation is on par for that. There are some scenarios where re-excision has to take place, and this is all going to be based on pathology. So this happens if the margins of that excision were not adequate. So if they didn't get all of that tumor or the neoplastic part out, they might do a re-excision. So this can be done, sometimes it's during the same operative session. So you'll see in certain scenarios, they'll actually do pathology right there on the spot. In that case, or they could tell for some reason, you can report the re-excision based on the final widest width excised diameter. And that's going to be required for the complete tumor removal, and that's during the same operative session. If they have to come back and widen the margins at a subsequent session, you can report that with the 11600 through 11646 codes, and you're going to have to append modifier 58, as it's a staged procedure then in that case. So use modifier 58 if the re-excision is done during the post-op period of that first excision. So let's take a look at our first example here. And again, we're looking for information that we need to code. So this is an actinic keratosis of the left upper cheek. It measures 0.5 centimeters by 0.8 centimeters, and then they did a 0.5 margin, and then they closed in a one-layer fashion. So just looking at this note, this is a really short little procedure note, but right off the bat, I highlighted actinic keratosis, so that tells me it's a benign lesion. The measurements, so I'll need to know that the 0.8 centimeter diameter and then the 0.5 margin, so that gives us a 1.8 centimeter excision diameter. And then the other important thing here is the one layer closure, and that's going to be included. So here we have 11402 as our code there. And this brings us right into our second polling question.
Oops, that's me. Okay, let me launch the poll. The question is, if an excision requires intermediate repair, report the repair separately. Is that true, false, or you are not sure? So if an excision requires intermediate repair, you need to report the repair separately. Is that true, false, or you're uncertain? And boy, we've got a quick response on this one, Shay. Let me close, share the responses, and we've got 100% once again is saying this statement is true.
Awesome. Yeah, you guys are correct. I just wanted to make sure everybody was paying attention because we're going to talk about repairs next. So that is true. You guys are correct. All right, so moving on to our repairs. So like I said, simple repair is always going to be included in your excision. You're not going to code that separately. A simple repair is a one-layer closure, primarily involves the epidermis or the dermis, or it can involve subcutaneous tissue without significant involvement. So a lot of times in the notes, you'll actually see like single layer closure or one layer closure, or sometimes they'll even say simple repair, but those are keywords that you'll look for. If it's intermediate, you're going to look for layered closure, and that's going to be deeper. So it could be fascia. Intermediate also includes single layer if it requires significant cleaning. That's probably not going to be the case in lesion removal. That's more for wounds. And then complex is more than a layered closure. It could be extensive undermining, stents, retention sutures. You'll look for things like that in your documentation. And we actually put together a little chart to help, again, just with some key words that you're going to be looking for, documentation clues. So again, in that documentation for simple, it's really going to be a straightforward repair. Sometimes they just use glue or like Dermabond. That's a simple repair. Again, intermediate, you're going to see layered closure. You might see them mentioning some of the deeper tissue. And then complex is going to be extensive, a reconstructive repair, involvement of nerves, blood vessels, tendons. That's going to be hints that you're looking at a complex repair. So let's take a look at these repair codes, starting with intermediate. So again, here's another handy chart for you guys to reference if you're coding a lot of these. These are divided similar to our excision codes, but a little bit different. So the body area groupings are slightly different than the lesion codes. So you can see those across the top, and then the length of the groupings are different depending on the body area. So there's actually one more code and more differentiation in the size of that last column for the face, ears, eyelids, nose, lips, and mucous membranes. So that one actually has a little further differentiation in the size, and you can see those codes listed there. For complex codes, there's not as many of these. So you can see the size is only goes up to 7.5 centimeters, and then we have that last row that says each additional 5 centimeters or less. So the differentiation is in the body area groupings and the measurements. So these are the complex repair codes. If it's 1 centimeter or less, it's going to have to be either classified as simple or intermediate. The guidelines for reporting repairs, I did mention this before, but it's a little bit different than the excision guidelines in the fact that you are going to add multiple wound lengths together if the wounds were repaired using the same technique. So they have to be either, both intermediate, both complex, and the repairs have to involve wounds at the same anatomical site. So you can add them together if those two criteria are met. And the repair is always based on the size of the defect to be repaired, not the lesion size. So that's another thing that might be missing in documentation. But again, it is needed for CPT. So if you're not seeing the size, go ahead and work with your providers on that. So the repair codes are based on longest length of the incision. So let's look at another example. In this example, we have two basal cell carcinomas. They were both excised and repaired with layered repairs. So the first lesion is on the left forehead. The diameter was 1.3 centimeters, and then the layered repair was 3.2 centimeters long. Lesion 2 was on the left cheek, and it had an excised diameter of 0.9 centimeters. It's near the ear, and the repair was 2.2 centimeters long and also repaired in a multi-layered fashion. So I'll give you guys a second to think about this one. I went ahead and highlighted some important information we have to pull out of this report. The first thing is that it's a basal cell carcinoma, so that leads us into our malignant excision repair, our excision codes. And then the second thing I have highlighted in purple for that first lesion is that it was on the left forehead, so we need to know the location, and then the excised diameter. And then in blue, that it's a layered repair. And then for lesion 2, we also need to know the location and the excised diameter, and then also that it was a layered repair and the length of the repair. So for our coding, for lesion 1, we'll report 11642, and then for lesion 2, 11641. So again, we're going to report both the lesions separately. We won't add them together for the excision. However, for the repair, we actually will add that together, and that will be CPT code 12053. And that's because we have the same type of repair and our body area fall into the same category there. So we'll add those two repairs together. So hopefully that's making sense to everybody. These examples really help illustrate our coding guidelines here. Next, we're going to talk about adjacent tissue transfer or flaps. So unlike repair, where we code the excision and then the repair separately if it's intermediate or complex, if they decide to do the repair with a tissue transfer or a flap, the lesion excision is not separately reportable. So if you're looking at reporting adjacent tissue transfer codes, That's 14000 through 14302. You will not be coding an excision code also. So only that adjacent tissue transfer flap in these cases. You can code donor site repair if the local flap or skin grafting is required. So that's only if a local flap or skin grafting is required for that donor site. But there's a picture of a flap, and we're going to talk a little bit more about types of rearrangements and flaps here. So you'll see these listed in your CPT book. These are all types of rearrangements or flaps, and they're considered adjacent tissue transfer flaps. You'll see these in procedure notes as well. The names of the rearrangement, so like Z-plasty, W-plasty, VY-plasty, they all reference the shape of the incision. And this is also the case with like rotational flaps, semicircular flaps. It's all referencing the shape of the incision, so that's what they're named for. The codes start at 14000 and then go through 14302. They are used for excision, so that includes lesion and or repair by adjacent tissue transfer arrangement. And you'll see, again, see in your CPT book the different types listed, so like Z-plasty, W-plasty, VY-plasty. So if you see that information in a note, you can go, reference your CPT book to make sure that's what it is, or always, you can Google it as well if you're not sure. So this could be for repair of either a benign or malignant lesion. Either way, that excision of the lesion isn't going to be included in these codes. Just a side note on that very last code for add-on code 14302, it's defined as 30 square centimeters or part thereof. So just wanted to point out here that part thereof means anything above the 30 square centimeters. It doesn't actually have to be half, like some of our other CPT codes, but if you have anything above 30 square centimeters, you can report it with 14302. And the defect size for the adjacent tissue transfer coding is a little bit different than what we talked about for our excision codes. So in the case of the excision with a type of adjacent tissue transfer, you can see here, so the dark red on the screen is going to be the primary defect, and that's going to be your lesion. So in this case, the diameter is 4. So here we're talking about, area. So here we're talking about area, not diameter. So you'll see square centimeter. So we're going to actually have to multiply the 2 by 2 for the primary defect. That's going to give us 4 square centimeters. The secondary defect is for the flap. So that is what they're going to pull over the primary defect. But the secondary defect is also by area. So that'll be multiplied again. So we'll have 2 centimeters by 3 centimeters for a total of 6 square centimeters in this example, and then we'll add those two together for a total of 10 square centimeters in this example here. So again, it's a little bit different than when we talked about the defect or the diameter, excision diameter for just our lesion codes. The defect size is what is used for the adjacent tissue transfers, and that's going to be your primary defect area plus your secondary defect area. So some multiplication needed there. And again, you'll see it different in provider's notes. Sometimes they'll just give you the area. Sometimes they'll give you measurements. But either way, you should be able to figure it out. And there are some examples in your CPT book as well. So we have a couple of graphic pictures next. Just wanted to give you guys a heads up. So look away if you don't want to see them. But I thought they were pretty cool. These are actually a coworker's husband's, I believe. But anyways, he had an excision with a W-Plasty Repair. And like I said, these are named by the shape. So on top, that picture is the excision. You can see it was very deep, and they repaired it with W-Plasty. So you can see all the sutures there, and that second bottom picture kind of look like a W. And he actually has, looks like some kind of drain as well. So this is an example of where you would just report the W-Plasty repair. We would not be coding in a separate excision with this type of adjacent tissue transfer. All right. Sometimes we see some complicated skin procedures being done where we have multiple lesions requiring flaps. We luckily have some CPT assistant guidance on this situation. So here it's just saying that if we have two lesions from the same anatomical classification, they're both removed and then they both require adjacent tissue transfer repairs, you can go ahead and report the adjacent tissue transfer repairs for each tissue transfer performed. And this is provided that the defects have distinct margins and are not contiguous. So if it's contiguous, it's not going to be considered two lesions, then it's going to just be considered one lesion. So be careful that, if you have providers doing this, they are getting that documentation in there to where you can tell that they have distinct margins, so that way you can code both of them. So let's look at another example. In this example, we have a lesion that's removed from the forehead, and it results in a 5.2 square centimeter defect. And then we have a lesion removed from the neck that results in a 7.3 square centimeter defect. And they both require rotational advancement flaps. So hopefully you guys are already thinking right away. If it's a flap closure, we're only going to be able to code that flap code. And then luckily in this note, it's giving us the defect measurement right off the bat, so we don't have to do any math. So here's our codes here. They both fall into the same anatomic classification that are defined by the code descriptors, and that's 14040. But they don't have contiguous margins, so they are representing two separate and distinct defects. So we're going to have one code for each of the lesions that were removed and repaired with advancement flaps. We are going to add a 59 or an XS modifier just to separate those two sites. So if your pairs are accepting XS modifier, that's going to be more specific than the 59 modifier, but if you have to use 59 modifier, this would be an appropriate way to do it since it is a separate site. So for flaps and grafts, we've only talked about flaps, but these are questions to consider. You're going to need to know, is the repair a flapped or a graft? So if it's a graft, you need to know what type of graft. So if it's a pinch, split thickness, or a full thickness graft, you'll need to know the measurements of the original wound site. And again, that's if it's a graft. And then was there site preparation other than the lesion? So did they have to take donor, was there a donor site prep that was separate from the lesion excision? That would be an example there. And then for the grafts, was that donor site repaired with a flap or a graft? So these can get a little bit complicated because we're, taking skin from somewhere to repair that excision site, but then we have to go back and repair where we took that original donor skin from. So again, these can get a little complicated. Draw yourself a picture, make a list, whatever you have to do to keep track of it in the op report. If the donor site was repaired with a flap or a graft, you can code that separately as well. So for reconstructive closure for the grafts, you can report that separately from excisions. For the topical placement of the graft, you'll see that could be an autograft, could be a skin substitute. You'll have to know the difference for the coding of the reconstructive closure of the grafts. And then just take note that excisions of lesions at the graft site can be coded separately. But like we talked about before, if it's a flap graft, like the ones we just discussed, those include excision of the lesion at the same site. All right, this brings us to our next polling question.
Okay, I just launched the question. The question is, if a malignant lesion is excised and repair with Z-Plasty, code both the excision and the repair? Is that true, false, or I don't know? So is this a true statement or a false statement? If a malignant lesion is excised and repair with a Z-Plasty, you code both the excision and the repair. Is that true, false, or you are uncertain? So we've got the majority of you who are pretty sure about your response. I think we've got a few tricklers who might be discussing it. Anybody else want to weigh in on this? Okay, I'm going to close the poll. 3, 2, 1. And again, boy, this audience is pretty consistent, Shay. All of them are saying that this is a false statement.
Awesome. Yeah, I'm glad you guys got that. It is false. You're going to report only adjacent tissue transfer. So Z-Plasty is an adjacent tissue transfer. So just that code for the adjacent tissue transfer. And just really wanted to hammer that home because it is an error that we've been seeing. So again, the CPT guidelines are very clear that if it's an adjacent tissue transfer, you cannot code that excision separately. So moving on, I told you we were going to talk about eyelid excision, so here are the codes. These are just something to be careful of. Some of the eyelid excisions have their own CPT codes, and these are in the eye section of the surgical codes. So there's not a super clear-cut difference in when you would use one, but the bottom, or the overarching rule, or the bottom line is, if it's mainly skin, then you're going to use the skin CPTs. But if we're getting into the eyelid itself, so that might be the lid margin, tarsus, conjunctiva, that's going to be an eyelid excision. So, you know, there is skin around the eye that's going to be in your skin section, but if we're getting into these types of anatomy locations within the eyelid, that's when you're going to jump over to your eyelid excision. And these are, from what I've seen, done in more kind of a specialty type office setting. So you might not see them being done by more of your primary or internal medicine type physicians, but you might. So just note, if you're seeing eyelid excisions, you're going to need documentation to really support it if you want to use these eyelid surgery codes instead of your skin codes. Some other excision codes that you see throughout your CPT book: the hidradenitis. This is a condition, it's pretty rare, but it's a long-term skin condition that causes small painful lumps under the skin. So they typically are going to develop where the skin rubs together. So like underarms, the groin, between the buttocks and under breasts are common locations. The lumps actually can break open and they can cause tunnels under the skin. So they will remove them. And they actually have their own set of CPT codes here. And unlike the regular excision codes, you're going to see the repair type is defined within the CPT code. So the repair is going to be included, but it does define your CPT code. So you'll see the difference between if it's a simple or intermediate repair, like for axillary body area, it's going to be 11450. If it's a complex repair in that same body area, 11451. If A skin graft or flap is used for closure. You can code that in addition. These are also unilateral procedures. So if it's a bilateral procedure, you'll need to add modifier 50 or follow your payer guidelines for reporting the both sides. These codes are right after the benign excision category. So just an FYI if you see those in your CPT book. And then Mohs surgery. This is kind of the last CPT topic we're going to talk about today, but this I kind of hinted at earlier. Mohs surgery is a specific surgery that they do for treating many basal cell or squamous cell carcinomas. So the procedure is done in stages, and the lab work is actually done while the patient waits. So this allows for removal of all the cancerous cells, and it does allow for the highest cure rate, and then they can also spare the most healthy tissue and leave the smallest scar as possible. So you can see kind of in the picture, the Mohs surgery is performed by doctors who are going to be specially trained to fulfill really 3 different roles. So as a surgeon, who removes the tissue, and then as a pathologist, they actually look at the frozen sections as they go, and then also as a surgeon who closes the wound. So it's done in stages, all in one visit while the patient waits. After they remove one layer of tissue, they examine it under a microscope in the lab on site. If there's any cancer cell that remains, they know exactly where it's at, and they'll go and remove another layer, and they'll just keep going. So they spare as much healthy tissue as they can, but they repeat the process until no cancer cells remain. So specific set of codes for this surgery, starting with 17311. And this brings us to our final polling question.
Okay, for our last question, if an excision involves more than the eyelid skin, such as lid margin and tarsus, which code or codes are appropriate? Is it 11440 to 11446? Or is it code 67840? Or you are uncertain? So if an excision involves more than the eyelid skin, such as a lid margin and tarsus, which code is appropriate or are appropriate? Is it 11440 to 11446? Is it code 67840? Or are you unsure or you do not know? We've got responses coming in. Now they're kind of, I think we've got maybe some discussion. People haven't finished really deciding where they're going to land on this one. Does anyone else want to weigh in before we discuss it? Okay, I'm going to close the poll, share the responses, and again, I think this is the first webinar where we have had the entire 100% audience has answered every polling question the same. So Shay, on this one, our audience is saying the code is 67840.
Yeah, that's correct. Good job, guys. So I guess everybody's paying attention, but if it's more than the eyelid skin, you're going to go to the eye surgery section. So that's going to be the 67840 code. So good job. So we are finished with our CPT portion. I'm just going to touch on ICD-10 for a little bit here and talk about ICD-10 neoplasm coding. Neoplasms are going to be classified in Chapter 2 of ICD-10, so that does include our skin neoplasm. They are classified by behavior, morphology, and topography. So broad behavior groups, so malignant, carcinoma in situ, benign, uncertain behavior, and unspecified behavior. The morphology or histologic type, that indicates the behavior of the neoplasm. So melanoma, carcinoma, and then the topography is going to give us our site or anatomical location. This is a tricky part of ICD-10 is the uncertain versus unspecified behavior. There is a difference. You're not going to assign uncertain behavior when the documentation only states lesion. Uncertain behavior is really a pathological diagnosis stating that the tissue of the neoplasm has been examined and does have a well-defined histological appearance, but the behavior, whether it's malignant or benign, cannot be determined. So I just wanted to make sure you guys don't confuse that with unspecified behavior. Unspecified behavior is category code D49. This is just a sign when the behavior or the morphology is not documented. So that lack of documentation should be rare, but it does occur, like if the patient's transferred and they don't have all the records yet, things like that. That's a good example of unspecified behavior codes. These are not all the code blocks for Chapter 2 for the Neoplasm Table, but here's the code blocks that you will most likely be using for your skin neoplasms. And you can see those there. We haven't really talked about in situ neoplasms yet, but that's when a group of abnormal cells which grow in their normal place are considered to form a neoplasm. So for example, you can have a carcinoma in situ of the skin or Bowen's disease, and that's just the accumulation of dysplastic epidermal cells within the epidermis only. So it stays within the epidermis and then it doesn't penetrate any deeper. So that usually appears as a flat lesion rather than forming a tumor. So there's specific codes for that. You can see there. In general, the general guidelines for neoplasms, they tell us that when the histologic term is documented, that term should be referenced first in the index before going to the neoplasm table. So here's an example of the neoplasm table, and it has the morphology on top and the sites on the left. This is for a neoplasm of the abdominal wall skin, and that could be either a basal cell or a squamous cell, or if there's another type of malignant neoplasm specified, we would get to C44.509. In the example of a malignant melanoma of the skin, the histological term melanoma, that's where you would go in the alphabetical index. It actually lists the side of the skin and it's going to provide a lot of different codes in category C43 for malignant melanoma of the skin. So in that case, the Neoplasm table is not referenced because the index and the tabular provide more specific codes there. So when you read through the index entry for melanoma, just be sure you note the correct subterm, because melanoma includes not only codes for malignant melanoma of the skin, but also a lot of the melanoma in situ codes. So those are going to be differentiated in that. And before you code, definitely be sure to check out your neoplasm coding guidelines. There's quite extensive Chapter 2 guidelines for coding neoplasms. I just listed out a couple here, or a few here that I thought were important, especially for skin. So there's a guideline for primary malignancies and overlapping boundaries. It basically says if there's multiple neoplasms of the same site that are not contiguous, such as tumors in different quadrants of the same breast, you would code for each site. There's also one for malignancies in 2 or more non-contiguous sites. There is treatment directed at a secondary site, and then when to use a personal history of malignancy neoplasm. So that personal history code comes into play a lot with skin cancer. So you'll see that the skin cancer is often treated, no longer being treated, but they do still monitor for it. So that personal history code can apply. And then to end today, I just wanted to review a few FAQs that are commonly brought up when we talk about lesion coding. So the first one is, do lesion removal codes have a global period? And may we file an office visit on the same day of the removal? So the lesion removals are considered minor procedures, so they're going to have 0 or 10 day global periods or post-op days. But because they're minor procedures, they're going to usually be bundled with the office visit. And what we've seen a lot of is that the patient will actually maybe come in for a physical or come in for a sick exam, and then they identify a lesion and the patient will actually be scheduled to come back and have the lesion removal done. And in the case of those scheduled procedures, the office visit really isn't going to be appropriate unless there's something completely separate that happened to be addressed while the patient is there. So you really have to look at the support for use of modifier 25 if you're going to try to bill an office visit with the lesion removal code. And if it's scheduled, that's a good clue that an E&M is not going to be appropriate unless there's something completely separate going on with the patient. The next one, if the surgeon is unsure of the histology of the skin lesion, but goes ahead and submits a specimen to pathology, can we go ahead and code it on that date of service? So we just wouldn't recommend it, and CPT assistant has said the same thing. Without the pathology report, you're really unable to accurately select a CPT code or an ICD-10 code for the removal. So we just recommend holding these claims until the pathology is returned. This is really going to be an internal policy that you would have to decide on. But hopefully your pathology gets back fairly quickly. So that way you can really select the benign or malignant CPT code appropriately. A lot of times you'll see a biopsy done on these beforehand, so they'll know whether it's a benign or malignant, but sometimes that's not the case. So again, for the CPT code, there's going to be a difference in the RVUs for those different, for the benign versus malignant series, and then your ICD-10 code will need to reflect the appropriate benign or malignant neoplastic code as well. So those are kind of our common questions, and I am happy to take any other questions. Kathy, if we got any, if we have time, that is all I have.
Perfect. Thank you, Shay, for a wonderful presentation. And yes, we just had 2 questions come through. So the first question is, if multiple lesions are removed during the same encounter, does a modifier need to be appended? And then if so, what's the modifier and which code?
Yep, that's a good question. So you are going to code those lesions separately. So bill for each of the lesions separately, and you're going to need a modifier, either modifier 59 or modifier XS. And that's going to clarify that the excisions took place at separate locations. So if your payer accepts XS modifier, that one would be more specific than modifier 59. But if not, modifier 59 works.
Thank you, Shay. And we've got time for one more. If multiple lesions are removed, but they're all described by one ICD-10 CM code, is it okay to link the same CM code to each CPT code?
Yeah, so that's a good question. It kind of goes along with the last one, but it's okay to have the same ICD-10 CM code as long as the lesions really were separate. You'll go ahead and report them both and link that same ICD-10 code to each of the CPT codes. The key is going to be your modifier, so either modifier 59 or XS, whichever your payer accepts, and then just make sure your documentation really supports that the lesions were different and being removed through separate excisions.
Thank you, Shay. Perfect. That answers those questions. So we want to thank everyone for your time and attention to today's webinar. On our closing slides, you will notice our upcoming events or our webinars. So for Prophy Coders, we've got in July, we're going to talk about E&M coding for that emergency department. And in June, we're going to do some PCS VIR coding. So please stay tuned or look us up on our website. So we hope to see you there, and then take a couple minutes as soon as you close out of today's presentation and fill out the survey for us. So again, thank you so much, and thank you, Shay, for a wonderful presentation, and look for a follow-up email from us within 2 days. Thank you so much, and have a great afternoon, everyone. Bye-bye.